Assalamu alaikum. Good morning. I'm really happy to be among colleagues in Saudi, and it gives me always the honor to be here. This is the third time I attend SSRC, and thank you for the invitation. Thanks for the scientific committee to choose, one of our work that it was a teamwork among different rheumatologists in the region. And a lot of work was also invested from our two amazing residents, which made this piece of art. I'll start with our amazing resident. This is Dr. Sara and this is Dr. Ahlam. It was presented in the ACR recently. And if you would like to see the poster, you can just scan the barcode. So as we know that rheumatoid arthritis is a systemic rheumatic inflammatory disorder. And TNF play a major role in the management of rheumatoid arthritis. And we know over the last 20 to 25 years, we learned a lot about TNF and how to tackle TNF in patients who are refractory. And we learned two concepts, mainly the switching or cycling and related swapping. And they were embraced or involved in the guidelines in the ACR and the EULAR. Those concepts were not implemented in JAK inhibitors, and we know that JAK inhibitors now are a major part of our treatment guidelines or treatment algorithms in treating patients with whom are refractory to conventional synthetic DMARDs. So with this notion, we had this, a clinical question: does cycling or switching between JAK inhibitors is applicable on a clinical basis? So with this, we digged into the literature. We looked more in depth, and we're having this, question in mind, whether the efficacy of safety of switching. And we have now more theoretical question about selectivity in JAK inhibitors. So we found this paper, and they showed that, it's safe to switch between JAK inhibitors, and this was more about tofa and baricitinib. Another paper in 2021 also had the same rhythm. And they showed that it seems that switching between JAK inhibitors is safe and efficacious. And this was more also between the first JAK inhibitor, which was tofacitinib and baricitinib, and the third paper in 2022. And most recently, also, there was a longitudinal data presented in the ACR showing the same theme or the same concept. So what we proposed that first of all, we had a cohort, rheumatoid arthritis cohort at Cleveland Clinic, and we looked at the overall safety of JAK inhibitors in the Middle Eastern, and we also collaborated with other colleagues in the region, from Saudi Arabia, from Jordan, and other hospitals in the region. But the main question was switching between a non-selective, a theoretical question. If you switch from a non-selective inhibitor, such as tofacitinib or baricitinib, to upadacitinib, is it safe and is it efficacious? So again, how did we enroll patients from different institutions, predominantly from the United Arab Emirates? We had patients from Saudi and from Jordan. We had 186 patients into this, comprehensive cohort. Out of those, 55 patients were exposed to UPA, and from those patients exposed to UPA, how many patients from those were switched from either tofa or bari to UPA? UPA were 27 patients. And what were the primary outcomes? We looked at baseline CDAI, DAS28, DAS-CRP, and after 6 months, we recalculated the same outcome measures, and we looked at secondary outcomes, drug retention, the reason for switching from a selective to a selective JAK inhibitors, and what were the adverse events. So if you look at the right side, that's the total cohort. The purple cohort is the cycling to selective JAK inhibitors. We had 27 patients, middle-aged, and they had a long disease duration, more than 10 years, and they were overweight, and majority were females. Majority of patients had a positive autoantibody profile. 40% of patients had a positive X-ray with erosions, and a couple of patients had a positive TB quant and had a history of zoster infection, shingles. All patients were previously commenced on a CSD-MARD, and of course, you know, if you look at the left side, all the patients were on a TSD-MARD, and majority were on, from the total cohort, were on tofacitinib because it had been in the market since 2012. But if you look at selectivity, of course, all of them were switched to upadacitinib. So what were the study outcomes? If you look at baseline, the CDAI was 29, and after 6 months, it significantly declined. Let me show you a better presentation of this data. And if we look here, if you look at the CDAI, there was a significant improvement from baseline after 6 months, and we saw similar improvement in the DAS, ESR, and DAS CRP after 6 months. And this, you know, supports the previous concept that if you switch or you cycle between, if you cycle between JAK inhibitors, still you can see a significant benefit. We looked at the drug retention and, you know, each drug for how long they stayed on. If we just start with the first bar, tofa, they have been on tofa for 17 months, bari 7 months, and then 18 months on UPA. Those were 3 patients. 17 patients were on tofa for 29 months, and then they were switched to UPA. 6 patients were on bari, and then they were switched to UPA. And 1 patient, actually the opposite. They went from tofa, UPA, and bari. But because the number is very little, we were unable to analyze, you know, do a sub-analysis of the opposite, switching from a selective to a non-selective JAK inhibitor. What was the reason for switching to a JAK inhibitors? Predominantly, majority of the patients were secondary failure, loss of efficacy after 6 months, 78%, 5% primary failure, and adverse events were in 7%. And if we look at the total cohort, what were the major side effects? I believe there's a new paper from Saudi Arabia by Dr. Al-Hamoud, very nice paper, recently published. And I think it replicates the same paper that, you know, geographically, if we compare our patients in regards to adverse events, I think it's similar to what we see internationally from other cohorts. And I see, you know, we don't see the same signal or the same trend as we see in other cohorts in regards to, you know, DVTs, MACE, and I think these are the main 2 adverse events that we care about. So in conclusion, our findings show that switching from a non-selective JAK inhibitors, which again is a theoretical concept, to a selective JAK inhibitor is feasible and safe, and that it may improve disease activity outcomes in patients who fail to achieve low disease activity or remission with the previous JAK inhibitors. So what's coming next? Inshallah, this year, we are working on a bigger cohort. We're extending the cohort to other institutions, and I want to thank all our contributors. A couple of pictures I couldn't find on the internet. Professor Suzanne, we are honored that she's part of it. Dr. Hanan, Dr. Hani Shatnawi from Jordan, Dr. Zaki Abu Zahra from Health Point in Abu Dhabi, from MedClinic, Dr. Hazem, Dr. Ahlam from Sharikha, and Dr. Mansour also agreed to be part of this study, and we're open, you know, if anybody from our colleagues here wants to participate, we're very happy to expand this cohort. I think the bigger the better. And of course, I want to thank all my colleagues. I mean, without them, I don't think this work will be presented today. All my colleagues in Cleveland Clinic, Dr. Meisler played a major role in designing the concept of this study. Dr. Hani Shatnawi participated too much into the study, and of course, our statisticians and our nice, amazing residents that, you know, implemented a lot of work in this study. Thank you very much. Thank you very much. Thanks for your attention. Thank you. Sorry I came late.